Cool. Good.
Okay. Hello, everyone. I'm Jim Karinji, faculty here in public health. I'm glad that people have been able to join us in person or on Zoom. This is our seminar session for the day. It's collaboration between the University of Montana School of Public Health and Community Health Sciences and also the Health Department and our Academic Health Department. So I'm happy to introduce Kristi Aklestad, who's coming from the Department of Health and Human Services, to talk to us about the great imitator, syphilis, historical and current perspective. So thank you for coming all the way from home.
Yes, thank you.
Yes.
Hello, everyone. My name is Kristi Aklestad. I am the section supervisor for the STD and HIV programs at the state of Montana, Department of Public Health and Human Services, and I'm excited to talk to you all about syphilis today. This has actually become one of my favorite topics in the last year. So happy to share some information with you all. All right, so what do a famous composer, a mobster, the emperor of the Qing dynasty, and a famous leader of the Nazi party all have in common? Not to name drop or anything, but Beethoven, Schubert, Christopher Columbus, James Joyce, Napoleon, Mussolini, Al Capone, Adolf Hitler, Vincent van Gogh, Nietzsche, several kings, and Leo Tolstoy were all rumored to have syphilis. And as we'll discuss today, sexually transmitted infections, and particularly syphilis, have been associated with stigma and have posed a threat to people since the 15th century. In World War I, they were the second most common reason for disability and absence for duty, and they were responsible for nearly 7 million lost person days and the discharge of more than 10,000 men. So only the Spanish influenza was a bigger cause of disability or lost person days during that time. So today we'll spend a little time talking about syphilis. So why are we still talking about syphilis? Syphilis has been around for hundreds of years, and its predictable clinical stages and well-established treatments made it a candidate for global eradication several times during the 20th century. However, the incidence in the United States and Montana is currently increasing, and control efforts have been hindered by clinicians, lack of familiarity with clinical presentations, the diagnosis and treatment. There. So this is the reported number of syphilis cases at all stages in Montana from 1919 when we started recording them to 2022. And for those of you who, it's pretty small up here, but 1919 is all the way over here, all the way over to 2022. And as you can see, Montana spent more than 6 decades with relatively low case counts and rates. In 2022, Montana reported just over 600 cases of syphilis. This was the most cases reported since 1948 and the highest rate since the late 50s. So far in 2023, we have even more cases than we recorded in 2022. We're right about 650 total cases of syphilis so far this year. So I'll spend some time in this presentation discussing the basics of syphilis, signs of infection, signs and symptoms, transmission, and the history of syphilis and current challenges in controlling it. So just to get us all on the same page, syphilis is a systemic infection, which is a little different than a lot of the other sexually transmitted infections. It's caused by a spirochete bacterium, Treponema pallidum. And the main thing that I want everybody to remember is it's preventable and curable. But without treatment, it can remain in the body without signs or symptoms and can cause late complications, which we'll talk about more. So syphilis has long been known as the great imitator because it can provide symptoms that resemble the symptoms of other conditions in many parts of the body. It typically follows a progression of stages that can last for weeks, months, or even years. So the signs and symptoms vary depending on the stage of infection. The primary stage is the first stage of infection, and this happens several weeks after the actual transmission has occurred. And the person will experience a firm, painless, non-itchy skin ulcer at the transmission point, and that's called a chancre. And one of the challenges to the chancre is that it resembles a lot of other ulcerative type illnesses that people can experience and looks like a lot of other things. So if a clinician isn't familiar with it, they may not actually recognize that that's what it is. But also because it's painless, a lot of people don't even know that they have it. They don't notice. So that will resolve without treatment, and the person moves into the secondary stage. The secondary stage is characterized by fever, swollen lymph nodes, patchy hair loss, fatigue, skin rashes and lesions in the mouth, vagina, or anus. When those can include mucus patches in the mouth, it can include a rash, like either on the torso, the face, the hands, like palms of the hands and soles of the feet, and also something called condyloma lata, which can look like genital warts. And that also resolves without treatment. And then the person moves into a latent stage. And that latent stage is characterized by a lack of symptoms. So as you can imagine, if you had a rash and it went away all on its own, you probably wouldn't go into the doctor, to have that diagnosed after it went away. And then you have no symptoms, but easily can move back into that secondary stage in that first year. So the next stages of syphilis are really defined more by the time period as opposed to symptomology because they're asymptomatic. So the early latent stage is when the infection has occurred in the last 12 months, but there are no signs or symptoms. And then the person moves into late latent, and that's when the infection occurred more than 12 months ago and continued to have no signs or symptoms. So untreated syphilis can result in poor health outcomes, and there are a number of different poor health outcomes that can occur. So for adults, one of those is neurosyphilis, and neurosyphilis can occur anytime during the infection, and it can result in a severe headache, muscle weakness, or changes to the mental state or dementia. Some people will develop something called tertiary syphilis, which happens about 10 to 30 years after their initial transmission if they're not treated. And it affects organ systems, including the heart and blood vessels. It damages their internal organs and can even lead to death. Other people will develop something called ocular syphilis or otosyphilis. Ocular is in the eyes, and it can result in permanent vision loss. And otosyphilis in the ears can result in hearing loss, ringing in the ears, or vertigo. And then another condition that we see associated with untreated syphilis is congenital syphilis. So this is when it's transmitted vertically during pregnancy from a mother to the infant. And 40% of people with untreated syphilis in pregnancy will experience miscarriage, stillbirth, or even infant death. And it's also associated with prematurity. We'll talk a little more about it in future slides. Syphilis is transmitted by sexual activity, vaginal, anal, or oral sex. And it's any time that the mucous membrane essentially touches another mucous membrane that's been infected. So for example, somebody could have a chancre in their mouth, and then even kissing could transmit that syphilis. And then it also has a vertical transmission during pregnancy, and that's just that vertical transmission between the mother and the infant that I was talking about earlier. The most common transmission, so you're most contagious during primary and secondary syphilis, and that chancre has a lot of syphilis bacteria on it, and so it's highly contagious if it touches another mucous membrane. For that vertical transmission during pregnancy, the stage that you see the most transmission is actually secondary syphilis because it's more systemically throughout the whole body. The treatment for syphilis varies only slightly based on how early it is. So we consider early syphilis primary, secondary, or early latent. It's that first 12 months that the person's been infected. And the recommended treatment in early syphilis is bicillin, which is penicillin, 2.4 million units intramuscularly in a single injection. The alternative treatment is doxycycline, 100 milligrams oral 2 times a day for 14 days. And then if that person progresses into late latent, or we're unsure how long they've had syphilis, more than 12 months, then they're recommended to have the bicillin, 2.4 million units IM, again, but 3 doses, spaced 7 to 9 days apart. And the alternative for that is, again, doxycycline, 100 milligrams orally 2 times a day, but for 28 days. And this presents some challenges for a lot of people. I don't know about you, but taking an antibiotic 2 times a day for 28 days is a long time to be compliant, even if all of the circumstances are great. But if you're unhoused or have other issues, it can be a challenge. And as we'll talk about later, the penicillin for late latent can also be a challenge because those doses have to be spaced 7 days apart. So, and I don't know if any of you have ever had a penicillin shot, but they're pretty painful. A lot of people call them a peanut butter shot because the actual penicillin is so thick that it's hard to push in, and it's very painful to your face.
Yeah.
It's very painful. Yeah. And in pregnancy, Vicillin is the only option because doxycycline is contraindicated. So one of the key factors in decreasing transmission between people is the management of sex partners. And how we do that is, when somebody's diagnosed, that gets reported to local public health. Local public health will follow up with the person who is the case, and they'll do an interview. And one of the things that they do in that interview is extract sexual partners. And for syphilis, it's a little more complicated because of the staging. So we're trying to make sure that we get all of the sex partners for the time period that the person could have been infected. So for primary syphilis, we interview 90 days before the onset of symptoms because that onset, that's the longest time period before you would see symptoms. For secondary syphilis, we interview 6.5 months before the onset of the secondary syphilis symptoms, and then early latent 12 months prior to the start of treatment. And then we look at those, we evaluate those sex partners differently too, based on how long it's been since they could have been exposed. So if their exposure was in the last 90 days, because they may not be showing symptoms yet or may not test positive, you do a clinical evaluation, test them, but you always treat them empirically. And then if their exposure was greater than 90 days, you do a clinical evaluation, test them, and you can wait and treat them based on their serological results, but in many cases, you'll treat them presumptively because the results aren't immediately available, and the opportunity to follow up might be uncertain. So that means that you've got them right then, and it's easier to treat them at the time. So now we're going to talk about historical perspectives of syphilis. So as with any, infection that affects a lot of people, we kind of try to assign blame, right, of where it started or understand where that happened. There are actually 2 origination hypotheses for syphilis, and these are in Europe because that's where we first saw cases reported. So the first hypothesis is a Colombian, and that is that syphilis was carried to Europe from the Americas by men who sailed with Christopher Columbus. And then the second hypothesis is that actually it was happening before Columbus sailed to America, but went unrecognized. And recent paleopathology dig results indicate that that's actually probably the case, that they've done digs and found bones that date back to the 6th century and were exposed to syphilis. What happened is the biggest outbreak occurred in 1494, and as with all outbreaks of things, we see something that happened most immediately and blame that, even if it isn't necessarily what it was. And Christopher Columbus, I believe, came back in 1493, so it's really soon after that. So the first recorded outbreak in Europe was in 1494 to 95 in Naples, Italy, during a French invasion, and they all pointed the finger at each other. But they think it may have been transmitted to the French from Spanish mercenaries. That outbreak led to spread across Europe, and the syphilis that they saw at that point in time had pustules that covered the body from the head to the knees, and it caused flesh to fall from people's faces and led to death. So it was a lot more fatal than the type of syphilis that we see today. It mitigated over time. So syphilis was a major killer in Europe during the Renaissance, and it was estimated that over 1 million people were infected in Europe. But about 50 to 100 years later, it started to become less virulent and less lethal. It was coined, so the term for syphilis was coined by an Italian physician in 1530, and until then they called it the French disease, or Lew's or Cupid's disease. Over the years, there have been a number of treatments for syphilis as well. And some of the common treatments for infections at the time were bloodletting, laxatives, and baths in wine. In the 15th and 16th century, they attempted to cure it with mercury administered by rubbing it into the skin, applying a plaster, or fumigation, which is vaporizing mercury over coals and then sitting on like a bottomless, it would almost look like a toilet seat over the coals so that it could fumigate the person. They also administered it by mouth. In the 19th century, it was administered by injection. Another treatment that came on later was they used malaria for a late disease, especially neurosyphilis, because it produced a prolonged and high fever, and that high fever might kill the syphilis bacteria. And then 1927 Nobel Prize for Medicine was actually awarded for this discovery. And then penicillin has been the recommended and effective treatment since World War II. And just to show you that, so this is that same graph of the cases in Montana, and you can see when penicillin came on the scene. And you can see the cases rapidly fall and then bounce back up for a short time period during another period of war. And then they came down, and for 60 years, we saw very few cases. So stigma is a socially undesirable attributes of individuals or groups associated with isolation, rejection, and discrimination. We're probably all familiar with it. It can be both external and internal. So internal stigma often looks like shame. External stigma is something that somebody puts onto somebody else. And it's really an essential contributor of the causal web of sexually transmitted infections that kind of allows them to flourish. So in the 1520s, it became clear to historians and physicians that syphilis was contracted and spread by sexual intercourse. In Europe, authorities became so concerned with the rise in venereal disease that they attempted to control prostitution and sexual encounters outside of marriage. Henry VIII tried to close down all the brothels and communal bathhouses in London. And in many other places, regulations were issued for brothels and bathhouses, forcing prostitutes who had disease or infection out of employment. In the 16th and 17th century, writers and physicians were divided on the moral aspects of syphilis. Some thought it was divine punishment for sin, and as such, only harsh treatments could treat it, and others thought that it couldn't be treated at all. In 1673, a British physician wrote an opposing view that the moral aspect of syphilis was not the province of the physician. They should treat all people without judgment. And stigma continues to be a challenge we'll talk about a little later. So it would be impossible to talk about syphilis and the history of syphilis without touching a little bit on the Tuskegee syphilis study. The Tuskegee syphilis study was conducted between 1932 and 1972 by the United States Public Health Service and the CDC. They enrolled 600 impoverished African-American sharecroppers from Macon County, Alabama, for a study that was to last 6 months. 399 of the men had latent syphilis when they were enrolled in the study, and 201 were not infected. And the purpose of the study was to observe the effects of syphilis when untreated. And it's really interesting because they were actually trying to compare it to the results of a Norway study that studied it in Caucasians. And their hypothesis was that Caucasians more typically had the end result of neurosyphilis, and for African Americans, they would have a different complication, and that would be more cardiovascular, so that tertiary syphilis. And they intended to have the study last 6 to 12 months, and then they intended to treat the people at the end of the study. But the treatment arm was determined to be too expensive, and so that part didn't happen, and they decided to move on with the study instead. And they reasoned that it was the greater good, that they were not harming the men involved in the study. They were really operating under the presumption that they were unlikely to ever receive treatment. So the participants were never informed of their syphilis diagnosis or the study's true purpose. They were provided ineffective treatment methods that had side effects of their own. And uncomfortable diagnostic procedures, such as spinal taps, were performed under the guise of it being a treatment. None of the individuals were treated with penicillin, despite it being readily available by 1947. And what happened is, though it was supposed to only last 6 to 12 months, it actually continued for 40 years. And there were a number of times during which some of the participants would have been offered treatment. So I think it was 234 of them were became soldiers in World War II, and they tested positive at military clinics, and they withheld, and so they had to get treated in order to continue in the military, but the U.S. Public Health Service blocked that treatment. And then again in 1947, they had public health clinics across the nation where they started to treat people with penicillin. And in Macon County, Georgia, they blocked that for the people that were a part of this study. So the study continued until 1972, when a leak from the press resulted in its termination. And 28 people that participated in the study died directly from syphilis. 100 died from complications related to syphilis. 40 of the participants' wives were infected with syphilis, and 19 children were born with congenital syphilis. So the Tuskegee syphilis study was a major violation of ethical standards and led to the establishment of the Office for Human Research Protections. It led to federal laws for the Office of Human Research Protections, led to federal laws and regulations requiring institutional review boards for the protection of human subjects. And it was the cause of distrust in medical science in the US government among African Americans. It's even come up recently with the COVID vaccine and how this related to that mistrust as well. So in 1997, President Bill Clinton at the time did an apology to the remaining men who were still alive from the Tuskegee syphilis study. And what he said is, what was done cannot be undone, but we can stop the silence. We can stop turning our heads away. We can look you in the eye and finally say, on behalf of the American people and what the United States government did was shameful, and I am sorry. Now we'll talk a little more about syphilis epidemiology and what we're seeing today. So this is kind of interesting just to look at. So on your left, 2012, I suppose it matters whether you're looking online or in person. Over here you can see in 2012, well, first of all, at the bottom is rates that you may not be able to see very well, but essentially as it gets darker blue, the rate goes up. So in 2012, across the country, as you can see, very little of the country was dark blue. Syphilis was a lot less common, and we were predominantly seeing it as an infection that affected men who had sex with men. So it was a much smaller population that was affected. And then by 2021, as you can see, there's a blue wave across the country, particularly in the South and the West, but really getting dark blue throughout. And then looking at who's affected based on race and ethnicity, you may be able to see the, as you go across, it's red is Asian, this one is Caucasian, green is Hispanic, Latino, multiracial. But the main thing I want you to notice is that across the board is this black line that goes up, and that's our American Indian, Alaska Native population, is highly overrepresented in current syphilis numbers. This is a graph of Montana syphilis cases just looking more recently. So on the left is 2020, moving towards 2023. And the 2023 case data is obviously not complete yet. This is the data through October 14th. So as you can see, we started to see a rise from 2020 to 2021 with a major rise in 2021 to 2022, and then we've continued to see that rise. So if I remember correctly, in 2021, we had about 200 cases. In 2022, we had just over 600 cases, and in 2023 so far, we've had about 650. And the other thing that we'll talk about in a little bit, but the orange line represents early, latent, late latent, and unknown duration cases, and then the blue line is primary and secondary. And as you can see, that early latent, late latent, unknown duration, that has continued to rise as well. We'll talk a little bit about the challenges associated with that as well. And then we'll talk a little bit about congenital syphilis and what we've been seeing. So just to remind you, congenital syphilis is vertically passed from a pregnant person to an infant during pregnancy. And the treatment for congenital syphilis is intravenous or intramuscular penicillin for at least 10 days. Congenital syphilis affects multiple organ systems and can cause jaundice, bone abnormalities, glaucoma, cataracts, lymphadenopathy, anemia, facial changes, abnormal tooth development, and deafness in the infant. So congenital syphilis cases from 2012 to 2021 are very similar to what we saw in the last slide. As you can see, even fewer cases have any blue to them in 2012, and then by 2021, that dark blue has really come across the entire country. So this is another interesting slide. This shows the number of congenital syphilis cases, or the rate, and then the primary and secondary syphilis rate in females 15 to 44 years. So if you follow the black line, that's the increase in rate in females from 15 to 44 years of age. And as you can see with that, the congenital syphilis cases increase. So we're really seeing this changing demographic in who's affected by syphilis. This shows the congenital syphilis case counts and reports by reported cases by race and ethnicity of the mother in 2021 in the United States. And as you can see here, American Indian and Alaska Natives at the top, they're overrepresented again in this case count. This slide shows Montana congenital syphilis, syphilitic stillbirth, and infant deaths due to congenital syphilis from 2020 to 2023, and that's that preliminary data, so through October 17th in this case. So before 2020, we would see 0 to 1 cases of congenital syphilis a year. And then in 2020, we saw 2 cases. In 2021, we saw 9 cases of congenital syphilis, and that included 2 syphilitic stillbirths and an infant death. So this was the first major leap for us, was in 2021. By 2022, we had 15 cases of congenital syphilis, and 3 of those were syphilitic stillbirths. And then so far in 2023, we've reported 15 cases of congenital syphilis as well, with 1 case being a syphilitic stillbirth. Recently, last summer, we did a deep dive into those congenital syphilis cases to look at them, and we're going to continue to do more of that. In fact, we've started a congenital syphilis case review board that will look into cases in detail to try to find areas for prevention. But some of the things that we found were that women with poor birth outcomes faced many challenges to care. So one of those was prenatal care. And of the cases of women who were pregnant when they had syphilis, what we found is that a much higher percentage of those that had the outcome of congenital syphilis had no prenatal care. So 51% of those cases had no prenatal care at all. Of the 49% who had documented prenatal care, 69% entered into that care in the 2nd or 3rd trimester, which is significant because the recommendation for pregnant women is to begin prenatal care in the 1st trimester. And also, if they entered in the 1st trimester, we would get that testing done and have an opportunity to treat them before that infant was affected by congenital syphilis. One of the other things that we noticed with those cases is the staging. So 77% of those cases were late latent or unknown duration. And that's important for several reasons. One is that like I mentioned before, there's a difference in the treatment, right, for late latent versus early syphilis. And that's that they have to have the 3 doses of bicillin, and they need to be spaced 7 to 9 days apart, which can be a major challenge. So we also saw that many didn't have appropriate treatment. So even if they were administered bicillin, it wasn't administered in the time frame that it needed to be, or wasn't so that spacing between doses, or they lacked treatment altogether. There were a number of missed opportunities, late or inconsistent medical or prenatal visits, but some had other opportunities where they interacted with the healthcare system and either weren't treated or it was missed somehow. And then communication. Some had unreliable communication methods, such as no phone, or had to be contacted by public health through Facebook. And this is just a quote that I think is really important to remember. So every case of congenital syphilis is a sentinel public health event. It means that there's a failure between the healthcare system and the public health system in order to address something that's preventable and curable. And David Harvey, who's the National Coalition of STD Directors, Executive Director, had this quote. There is not a single baby that should be born in the US with syphilis. We will be judged very severely as a country and as a society for allowing this to happen to babies when it is so easy to diagnose and prevent this, to treat and prevent this disease. So now we'll talk a little bit about the challenges to addressing syphilis. One of the challenges is treatment. As I mentioned earlier, the recommended treatment for syphilis is bicillin, and it's the only treatment that can be used in pregnancy. And last spring, we were notified that there was a shortage of bicillin, and they thought at the time that it would last a couple of months. And so we reacted, but not to the level of we hadn't seen any shortages yet and weren't sure that they would affect us. But then within a month or two, we found out that they predicted that those shortages would last well into like Q4 of 2024, which is significant and worrisome. So bicillin's only manufactured by one company in the United States, Pfizer. And my understanding is that the making of bicillin is actually very difficult. They have to grow the mold. Essentially, it's that they use for that in a special laboratory, and there's really only one place they do it, and they only do it every 2 years. So in order to, they have to project essentially how much bicillin they're going to need, and then they produce that much of those ingredients and produce the medication. Well, the projections didn't take into account, increases in the syphilis that we're seeing. And even if they had like an accurate case count, I think that if you didn't factor in things like that, so many of the cases would be late latent, for example, and need 3 doses, and that many people wouldn't get those doses on time, so they might need actually more than 3 doses so that they could get the doses spaced appropriately. So some people are getting multiple rounds of bicillin because it's not happening in a timely way. So it would be very hard to predict. But then on top of that, there was an amoxicillin shortage, and so they made recommendations to treat some other illnesses with bicillin at the time, and that also affected it. And so there were a number of factors why this is, but penicillin and bicillin in particular is in shortage right now. In Montana, we have not had a lot of reports of people having shortages yet, but we have asked communities, local public health, to track their community supply and make projections regarding how much they'll need so that they can stay on top of that in order, because they're on allocations essentially for that. And then there are challenges too if you treat people with doxycycline, which is the alternative treatment for those who aren't pregnant, there are some major challenges to getting people to be compliant with 14 to 28 days of antibiotics. So definitely challenges. Another challenge that we're seeing is that a lot of our cases, 61% are staged as late latent or unknown duration. And from a surveillance perspective, the assumption when you stage someone as late latent is that the case is less contagious. From a clinician standpoint, the assumption is that if you're unsure, for example, the person isn't a good historian and can't tell you or didn't even know that they had a chancre, that you're not sure if the rash that they report having was in fact due to syphilis, might think it could have been, atopic dermatitis or something else. There's a number of reasons why it can be really challenging to diagnose somebody if you're not seeing their symptoms in real time as in that early stage. And so many people are staging it late latent because they feel like that's safer, right? Because then the person will get the 3 doses and they know they're treating them appropriately. But then on the converse side, that can be really challenging because not all of those people actually come in and get the doses spaced appropriately apart. So that's a challenge on the treatment side. And with the shortages, it's another challenge on the treatment side. And then the management of sex partners is different for late latent. So as I mentioned earlier, we look at that time period for early syphilis that the person could have been contagious. So we're going back 90 days from primary syphilis, 6.5 months from secondary syphilis. The management of sex partners for late latent is actually to just look at long-term partners because they're assuming that they're not or haven't been contagious for a period of time. But if we're having trouble staging the person appropriately, that might not actually be the case. And so the whole management and control of the disease depends on decreasing transmission by treating those sex partners. So there's like a circle of challenges essentially associated with the staging. And then stigma. Stigma is an essential contributor in the causal web of STIs, and stigma is really amplified when we separate people into sexual and behavioral categories associated with disapproval, rejection, and exclusion. And we can really see this kind of going back all the way, even as we talk about the history of syphilis. There was stigma back in the 1500s about syphilis, and that caused people to be very judgmental of sexual practices and just associate it, with low morals, essentially. And that's been a challenge that has continued as we've addressed syphilis even 400 or 500 years later. Stigma, whether it be internal, that shame, or external stigma, causes people to avoid seeking STI-related services because of their experiences, such as discrimination, indifference, and overt hostility. And it's really important as we look to address stigma because it's one of the major factors that we see as a challenge really in addressing this, that we think about person-centered approaches and non-judgmental, person-centered sex positivity in our culture, and really thinking about, sexual reproduction and sex as part of the human experience, and trauma-informed care practices, really thinking about the traumas that the person brings and not contributing to those, and also addressing those in care. And then community engagement to prevent it and to normalize seeking healthcare services. Does anyone have any questions?
Thank you.
Yeah.
We can have questions in the chat too. I can start with a question, Kristi. As a big pharma skeptic, I'm just curious. Sorry, pharmacy people. The bicillin, is that generic at this point? Is it proprietary? Because I'm just wondering why one pharmaceutical company is not making it only. Is it not profitable? Do you have any ideas about that?
I actually am not an expert on that, but it's a great question. And it's been around for a really long, like since 1947.
Then there's no way, yeah.
Yeah, I do believe it may be generic, but, and to be honest, though, Vicilin is interesting because on the open market, it's pretty expensive actually per dose. And I don't know if everyone's familiar with 340B drug pricing, but federally qualified health centers and a number of other types of clinics, including Title X, family planning, and STD clinics, have access to 340B drug pricing, and it's actually like less than $1 on 340B per dose. So it can be bought very inexpensively if you have the right access. But I don't know why only one company is the sole manufacturer in the United States for it.
So thank you. And a follow-up, do you know if there's any other research being done for other medications that might work and or vaccines or anything like that?
Yeah, great question. So I do not know about any vaccines that they're looking at. I also don't know if they're looking at other treatments for it. From what I understand, it can be really hard to treat anybody with less than the standard of care, right? The standard right now is that we know penicillin works. And so it would be wrong, right, to not treat somebody with penicillin. And so that creates its own kind of problems. And because of the shortage, there's been a lot of pressure on the CDC as well. I know that the state health officers have been putting some pressure on them to come up with other solutions as well. But to my knowledge, there haven't been any that have been adopted so far.
Yeah, I have a couple questions. So my first one is doxycycline, is that like, is resistance or antibiotic resistance common with doxycycline? Because I know that that's prescribed for a lot of other things, including acne, which is like a very common.
Yeah, that's a great question. So I've also asked this recently because doxycycline, the CDC is in the process of coming out with a recommendation for something called DoxyPEP, which is doxycycline as prophylactic. Now I'm going to say it wrong, but essentially after an exposure, you can take it prophylactically and prevent essentially an infection with chlamydia. And so they are looking at it, but my understanding is there actually isn't a lot of resistance for doxycycline, and it is a well-used and very accessible medication.
And then my other question was, did like decrease preventative health services or health education services partially play into that? Like, did COVID impact the funding, and has that funding been replenished, or like especially in like AI population or whatnot? Are they still receiving those preventative services that they need for health education and condom use?
Yeah, I think that's a great question. I think what you're asking is, did the COVID-19 pandemic affect those syphilis numbers and that outbreak? And I think that we don't know for 100%, right? It's impossible to go back and see exactly what would have happened if we didn't have the COVID-19 pandemic during that time. But what we do know is that during the pandemic, some resources, including local people who do disease investigations and interventions at local health departments, some of those people were pulled off of those tasks, right, and put onto investigating COVID cases and managing COVID. And also during that time period, we saw a real decrease in people being able to access healthcare for a variety of reasons, some of which was self-selecting not to receive care during that time because it was harder to get in and everything. So it may have definitely played an impact on it. My understanding though is that there was no change in funding. We didn't necessarily see a change in funding at the state level. We also haven't seen a commensurate change in funding to address syphilis. And we get very limited dollars into the state health department to address sexually transmitted infections in general.
Thank you.
Yeah.
We have a question. Well, first off, we have a comment from BRAD who says, thanks for the presentation and all the support you give to the local health jurisdictions. And then Elise is asking how DPHHS is working with tribal communities to address the high syphilis rates.
Yeah, it's a great question. So thanks, BRAD, first of all, and then Elise, we are working with our tribal jurisdictions. So one of the things that we did recently, actually, let's see, in 2023, we have worked with our partners in our maternal child health programs at Family and Community Health Bureau at DPHHS. They had some funding that they were able to put aside for some of these efforts. And we held a series of syphilis symposiums across the state in several of our tribal communities. So we brought in an expert from the CDC who, her name is Dr. Melanie Taylor, and she has been treating syphilis for years. And we took her to 5 different sites and educated about 300 people on syphilis and you know, all of the factors for how to treat it and mitigate. And so that happened across the state in June. We had a number of billboards that went up in our tribal communities. And then we also have been had some advertising on social media as well about syphilis and the rise in syphilis. We partner with both local health jurisdictions and tribal jurisdictions in order to help support their efforts. And we've been partnering with several of the tribal entities that are the most affected to help support their staff, whether it be with data entry, education as needed, training. We've seen some turnover in the workforce, and so we've been a lot of additional support in those areas for that.
Great, thank you. And we also had a comment early in your presentation from Yellowstone County about high rates there. And then we also have a question from Yellowstone County that if a non-pregnant person diagnosed with a latent syphilis infection receives bicillin doses outside of the 7 to 9 days apart schedule, like 10 or 11 days, do they need to restart the series?
Yeah, that's a complicated question, and the recommendation right now for even for non-pregnant people is the 7 to 9 days. There's like a little caveat in the STI treatment guidelines for syphilis for bicillin that in some cases clinically it can be between 10 to 14 days, but it's not very empirical, and so we've gone with the 7 to 9 days as the recommended treatment.
Thank you.
Yeah.
Do you have any other questions?
I have one. The graphs of like trends over time, like it's pretty alarming where we're at right now, right? I mean, it was pretty low for so long. Is it predicted to get even higher, or is it going to level off? And if it's going to keep going up, like what's the plan?
It's a great question. Yeah, I mean, right now, it doesn't look like it's gonna level off, although it also doesn't look like exponentially grow as much as it did. So we saw that huge growth, right, between 200 cases and 600 cases. So far this year, we're at 650. That's not that much over last year. It looks like we might like slow the growth a little bit. Initially, growth in cases is an odd thing. It's not always bad, right? It means that we're catching them. And so to see a huge drop off wouldn't necessarily indicate that all of our efforts were working, especially if we aren't, you know, capturing data on sexual partners and following up on all of those sexual partners. So at first, growth actually isn't always a bad thing. It means that we're catching the cases. We would like to see it start to come down, level off, and come down over time, but that will take some intense effort in some locations in order to make that happen. And that's challenged by a number of factors, including funding, obviously, and then the treatment issues with bicillin and shortages of medication. And then also the populations that we're working with, it's not always easy to manage them and find them for treatment, and then find their partners as well. So we hope to see it level off, but we are looking at that. And then particularly with congenital syphilis, we do have plans to really start digging in on that. So during the course of this last year, we hired a nurse consultant to address that and to provide support to local and tribal public health. And then she will also be creating a congenital syphilis case review board that I mentioned earlier. So we'll be looking at those cases in depth to see what areas we really can affect. Great question. Thank you.
Having the congenital syphilis case review board is just an excellent, just sounds like such an excellent, I guess. It'll eventually be a safeguard. It's not maybe not a safeguard yet, but maybe this adds on to Tony's question a little bit. If you use chlamydia, for example, if you look at the case rates of chlamydia that are just, you know, if you use it as a surrogate for open pathways for if syphilis becomes present, which it has, and potential syphilis cases, there's a lot of potential, unfortunately, because the chlamydia cases are hundreds and hundreds, just in this county, hundreds and hundreds every year. So I'm very concerned about that potential. Also concerned, especially with neighboring states, the loss of a lot of the OBGYN care that is a secondary result of the abortion restrictions, and some of those practices are just, and those doctors are just closing up shop and moving out of Idaho, for example. And I think that's going to open yet another loophole where some of the syphilis congenital will get through. So I was really glad to hear that you already come up with that congenital syphilis review board. That's a good move.
Thank you. The other thing that we did actually very recently in the last couple of weeks was sent out a letter to all people who provide care to women's health, so women's health care providers, particularly those that may see people in pregnancy, and recommended triple screening. So it is required by law to do a syphilis test at the first prenatal visit. But we've also, we've seen that people might test negative at the first prenatal visit, but they continue to have sexual partners and could test positive later. So we've recommended that they test, and this is in line with the CDC recommendation, but at the first prenatal visit at 28 weeks and at delivery for all people, because really testing, screening, and then treatment are the only ways that we can prevent congenital syphilis cases. So we did that recently. And then for people who don't seek prenatal care, we're recommending it with every positive pregnancy test if they haven't, regardless of the purpose of the visit, and then in EDs and urgent cares if they haven't sought prenatal care as well.
Can I ask what the cost is for treatments and diagnostics, especially for like uninsured people or people who have lost Medicaid? That's really big monitoring right now.
Yeah, that's a great question. It definitely will vary based on, so the test of the cost of the test would vary depending on where you sought care, but the state health laboratory, it's about $150, $160 for the complete testing, and that's if you have to reflex. So it actually requires 2 tests to test positive for syphilis, which is another challenge. And so for most people, they would just have the 1 test, and that one I think is about $38. It's relatively inexpensive. And then if that's positive, it would reflex to the other tests, and it was right around $150. And so it doesn't have to be super expensive, but it will definitely vary based on where you're tested. And then the treatment again will vary based on where you're treated as well, because if the site has access to 340B, it could be a lot less expensive because they get it for so much less. And so some of the places where you could seek care if you were looking for inexpensive care are those places that offer a sliding fee scale, federally qualified health centers, family planning clinics that are funded by Title X, and ST clinics around the state. And local public health is a great resource for finding those sites as well.
Well, Kristi, thank you very much.
Thank
Appreciate
you.
you coming. It's a great presentation, and I'm sure we all learned a lot. I know I did.
Well, thank you. Thanks
Thank
for
you.
attending.
Absolutely.